All right. Hi, everyone. I will get us started. So good evening. My name is Vicky Mercado, and I am a fourth year MD PhD student at Baylor College of Medicine. Thank you so much for joining us for our second segment of our 5-part anti-racism teach-in series. At the first seminar, Dr. Camera Phyllis-Jones gave us valuable insight about how we can be better partners or allies, along with how to build our toolkit to advocate for racial justice in our community. So now that we've laid the foundation of essential items in our anti-racism toolkits, today we will examine racism in healthcare and science. So the history of medicine and science is really plagued with racism and injustices towards Black and Brown patients, from incidents like the Tuskegee study and appropriation of biological samples such as with HeLa cells. It's very clear that medicine and science are not immune from systematic harm towards minority populations. So today we're going to have 3 phenomenal women shed light on the manifestations of racism in healthcare and science. So before I begin introducing our speakers, I would like to take a moment to thank the students who continue to work so diligently to putting this series together, as well as the various BCM and UT Health organizations that have sponsored this event. So this event was made possible by students and trainees who founded the Medical and Science Coalition for Activism, or MSCA, an organization whose mission is to advocate for marginalized groups and make our community more socially just, diverse, inclusive, and equitable. So be sure to follow MSCA on Instagram, Twitter, Facebook. Also feel free to visit our Linktree site that has all of our resources in one space. And that will help you also figure out how to get involved and stay connected with us. So all of this information can be found in the chat feature of Zoom. Also note that this session is being recorded and will be archived so that you can view again if you would like to. And you can submit any questions that you have during the talk via the Q&A section at any time. So we're going to have a few members of our team monitoring the questions, where we will ask them in a moderated Q&A after our 3 presentations. So now to begin introducing our 3 amazing speakers. So panelists, when I introduce you, could you please wave at the audience and say hello so that everyone knows who you are? All right. Great, so let's get started. First, I will introduce Dr. Rayne Rouce. Dr. Rouce is a pediatric oncologist at Texas Children's Cancer Center. And in addition to being a physician scientist, focused on immunotherapeutic options for high-risk leukemias and lymphomas, she is an avid educator, volunteer, and social justice activist. Dr. Rouce was born and raised in Houston, and she completed her medical training and residency at UTMB in Galveston, Texas. And during this time, she was honored as Resident of the Year through each year of her training, and also recognized as the outstanding overall residence from over 600 residents. So she went on to complete a chief residency year, during which she received an award for excellence in resident teaching. Dr. Rouce subsequently completed the Pediatric Hematology Oncology Fellowship Program at Baylor College of Medicine and was drawn to research in refractory leukemia lymphoma, given her passion for helping the underserved. She has been invited to present her research internationally, is widely published, and was recently chosen as one of the 100 inspiring Black scientists in America. In addition to her translational research, which she has received numerous peer-reviewed grants and awards for, she is Associate Director of Community Outreach within the Office of Diversity, Inclusion, and Equity at Baylor College of Medicine. She's incredibly passionate about creating a pipeline of future healthcare workers and scientists that come from underrepresented minority and lower socioeconomic backgrounds. and leads several programs, including Saturday Morning Science and Doctor's Day Outreach for the community. More recently, she has used her platform within national and international scientific societies, as well as foundations such as Stand Up to Cancer, to amplify the inequalities in access to healthcare, as well as consideration for clinical trials for minority patients. She is a longtime volunteer for the Periwinkle Foundation and also a student advocate who amplifies the voices of trainees in the medical center. Thank you, Dr. Rouce, for joining us this evening to discuss racism in healthcare and science.
Thank you, Vicki. I'll briefly unmute because we realized that unless I spoke, they weren't able to see my video. So hi, everyone. Thank you so much, Vicki. That was an amazing introduction.
You're very welcome. Okay, so next, Dr. Stacy Lloyd. Dr. Lloyd received her Bachelor's of Science in Biology and the Biological Sciences from Prairie View A&M University prior to receiving her Master's of Public Health and Doctor of Philosophy in Human Genetics at the University of Pittsburgh. At the University of Pittsburgh, she was a grant awardee from the University of Pittsburgh Cancer Institute for Cancer Epidemiology and Cancer Prevention, and was also an NCI Diversity Supplement awardee. After receiving her doctorate, Dr. Lloyd was a Kellogg Health Scholar postdoctoral fellow at MD Anderson Cancer Center in the Center for Research on Minority Health. And she also served as a member for the Houston Breast Cancer Task Force. Dr. Lloyd is an adjunct professor at Texas A&M Corpus and an instructor in the Molecular and Cell Biology program at Baylor College of Medicine. We look forward to hearing her thoughts on racial disparities in scientific research this evening.
Hello, happy to be here with you all.
Grateful to have you. Okay, and finally, last but certainly not least, Dr. Renata Nero. Dr. Nero is a licensed clinical psychologist in private practice and a distinguished educator in her role as a professor of psychology at Houston Baptist University. Dr. Nero earned a Bachelor of Arts degree in psychology from Fisk University and a Master of Arts degree in Afro-American Studies from UCLA. She was awarded Master of Science and Doctor of Philosophy degrees in clinical psychology from the University of Massachusetts at Amherst. She also completed pre- and postdoctoral internship training in clinical psychology at Baylor College of Medicine. Dr. Nero has also received national recognition for her teaching and for her outstanding service to the community. She has over 25 years of experience in leading workshops on issues related to mental health and is the former president of the Southwest Region Board of Directors for the Christian Association for Psychological Studies. We are grateful and so excited to have Dr. Nero share her experiences and insight with us regarding mental health disparities of Black individuals, especially Black trainees.
Thank you very much.
My pleasure. Okay, so with that, we are going to get started with our first speaker for the evening, so I will turn that over. And again, thank you so much for being with us this evening and sharing your insight.
All right, good evening, everyone. I want to make sure that everyone can hear me and can see my screen. Maybe a thumbs up or a yes in the chat would be helpful. All right, perfect. All right, so first I want to say how thankful I am to have been invited to present to you guys. This is an amazing group of students who have single-handedly put these events together, and I think they are beneficial for all of us in medicine and in science. So I'm honored to have been considered, and I'm excited to talk about this because I'm very passionate about it. So I'm going to speak this evening about the impact of systemic racism, both implicit and explicit, on health. And this is a receipts-based discussion because we're scientists and we're health professionals, so we have to check our receipts. So there's not a website you can visit or a channel you can turn on these days without being reminded of the glaring impact of COVID-19 on America. But more recently, and these are headlines all from last week, we've been reminded that there are a number of disparities that occur and make COVID-19 even worse for our people of color. It's important, though, to realize that COVID-19 has not created these inequities in health. It's simply become a magnifying glass that helps us see some of the long-standing shortfalls that have existed for minorities. So what have we learned thus far about COVID-19 in communities of color? Well, some of the first reports that showed the stark racial disparities in COVID-19 came out of Wisconsin and Michigan, where they released data showing that over twice as many Blacks in their population were actually infected with COVID-19. So the media quickly picked up these reports, and a number of other states began to report that the percentage of Blacks affected were over twice that of Blacks in the population. This led to elected officials calling for a more thorough collection of racial data. And so let's take a step back and see how well we've done over the last couple of months since we first saw these red flags in early April. So this is actually from the Johns Hopkins Coronavirus Resource Center, and they update this every day, typically early in the morning, and this is updated from July 23rd. So what we've seen is that where at the beginning of the pandemic, only a few states were actually reporting race data for confirmed cases and for deaths, now the vast majority are, but we still are greatly lagging behind with only 5 states actually reporting and releasing data on race, and we'll talk about why that's important. So one of the common myths or misconceptions that has been propagated is that people think that perhaps COVID-19 is only disproportionately affecting communities of color in densely populated urban areas. But this is from the CDC website, and I dug through all this data, and not surprisingly, that's not the case. So this is showing coronavirus cases per 10,000 Black residents, and I chose a number of different counties across the United States, both densely populated urban counties, rural counties, suburban counties. And as you can see across the board, Blacks are often 4 times as likely to be infected with coronavirus. And if you look closely, you see Hispanics are not that far behind. And in counties where they actually reported and collected this data, Native Americans as well. When we look at hospitalizations, and these are age-adjusted COVID-19 associated hospitalization rates from March to June of this year, you can see that Hispanics, non-Hispanic Blacks, and Native Americans are often up to 5 times more likely to be hospitalized with COVID-19. So what does that mean? Well, it means that they likely had more serious illness. What is that related to? It's possible that they may not have had access to health care earlier on, so they present at a later stage. Unfortunately, when we look at deaths, we see the same pattern. In this figure, and again, this is adjusted by age and race, so we know that elderly are more likely to succumb to death due to COVID-19. We see that Blacks are often 4 or 5 times more likely to die than whites are. And this data holds true in every single age group. So why? Why is this the case? There are a number of questions of bias in COVID-19 treatment that have been raised recently. And I think most of the people on here, if you watch the news or if you're on social media, you'll see reports about people wondering, why was I sent home from the hospital? Why was I not tested despite having symptoms? So I'm a scientist, like I said, and I know I have a lot of scientists on here. So scientists, we look at evidence-based medicine, okay? So I look for the receipts. I tried to Google a receipt for systemic racism. I was unable to find one, so I had to create my own. So this is a self-issued receipt, systemic racism. The cost was $0, but we have some tips on the following slides. So there are long propagated myths about physical racial differences that have been used throughout the years to justify slavery and are still actually believed by doctors today. This may seem unbelievable, but I'm going to show you why it's not. So some of you may be familiar with the 1619 Project of the New York Times, and it looks at not only the historical relevance of racism in America today, but also its impact on not only daily life, but on healthcare. Now, while it may seem unrelated, There are a number of studies that show that it is not. So in 2013, the AMA Journal of Ethics actually published a review series examining racial disparities in pain management. Black and Hispanic patients received inadequate pain management compared with white counterparts. This is on surgeries as minor as a tonsillectomy, but also even when considering hospice care. In 2016, 222 white med students and residents were surveyed, and this was published in PNAS. 50% of these med students or residents endorsed at least one myth about physiological differences between Black and white people, including Black people's nerve endings are less sensitive than white people's. When asked to imagine how much pain Black and white patients experienced in hypothetical situations, 50% surveyed insisted that Black patients were in less pain. A third of those surveyed believed the myth that Black skin is actually thicker than white skin. So let's talk about evidence-based medicine. In 2017, a systematic review compiled all research on implicit bias amongst physicians. And again, this was published in the Academic Emergency Medicine Journal. And they looked at 9 studies. Most of them used clinical vignettes. And they found that the majority of people that responded found an implicit preference for white patients, especially among white physicians. 2 studies even found relationships statistically significant between bias and clinical decision-making and practice, and 1 study actually found that bias was associated with a greater chance that whites would be treated for a myocardial infarction or heart attack than Blacks. In 2014, the Journal of American Board of Family Medicine surveyed 543 internal medicine and family medicine physicians. And this survey actually asked about medical cooperativeness of patients. And this is often something that practitioners take into account when they're considering treatment options. They asked these practitioners whether they would recommend knee replacement for osteoarthritis, and they gave identical case descriptions, but some with white patients, some with Black patients. And what they found that overwhelmingly practitioners were more likely to recommend a knee replacement for white patients because they were quote unquote more medically cooperative without any other confounding factors. So what does this mean and why does it even matter? This disconnect allows doctors, scientists, healthcare professionals, and most importantly, trainees to ignore their own complicity in healthcare inequality. It allows us to gloss over internal racism, ignore implicit and explicit biases, perpetuate centuries-old beliefs of physiologic inequalities that are not true. It allows us to place blame on individuals and their communities for statistically poor outcomes. And so if this is the case, I implore you, are we really doing no harm? I love this quote, so I always include it, and I'll read it in its entirety because I think it's so important. Rather than conceptualizing race as a risk factor that predicts disease or disability because of a fixed susceptibility conceived on shaky grounds centuries ago, we would do better to understand race as a proxy for bias, disadvantage, and ill treatment. The poor health outcomes of Black people, who are the targets of discrimination over hundreds of years and numerous generations, may be a harbinger for the future health of an increasingly diverse and unequal America. So now that we're 6 months into COVID-19, what have we actually learned about COVID in communities of color? Well, not surprisingly, there are a number of similarities to past pandemics and natural disasters. We're in Houston, so of course we're very familiar with the disproportionate effect of natural disasters like hurricanes on people of color. Most socially marginalized populations will suffer disproportionately. Racialized characterizations of behavior, such as obesity, and assumptions of biological predispositions can actually be more harmful than helpful. Geographic disaggregation must be interpreted with caution. What does this mean? There's something known as territorial stigmatization. Resource-deprived neighborhoods can often suffer from a blemish of place. This leads to blaming of alleged deviant behavior, repressive surveillance, or even neglect. And we see this day in and day out on the news. The reality is that COVID-19 disparities persist across state and county lines in cities, suburbs, and rural areas. So let's do a root cause analysis. We're scientists, we're healthcare professionals, this is what we do. So yes, it is true that many people of color actually do have existing chronic conditions that increase the rate of complications and death for COVID-19, as well as a number of other illnesses. But why is this? Well, for one, there are inequities in socioeconomic status, racial housing segregation, food deserts, living conditions, and poor access to healthcare. And you add to this some inevitable high-risk factors. Many people of color are essential workers. They don't have the ability to have paid sick leave. They can't just as easily work from home. They often serve the unmasked. They have to take public transport. They have to go frequently shopping for necessities because they can't afford to stockpile. Delivery services often are not available in their area. They may not be able to get Instacart as easily as someone else. And social distancing may be impossible, especially when you are in a multi-generational household. And they have reduced access to virtual health care. It requires broadband. How can you go through drive-through testing if you don't have your own vehicle? Limited or delayed access to testing often leads to later diagnosis and treatment, which likely contributes to the increased level of hospitalizations. And why is this? Well, we have to look inward. We know that there's implicit bias in healthcare. We know that there is inequity in access and resources, and we know that there is mistrust that is often rooted in historical context in this country. So I'm going to switch gears for a bit and talk about clinical trials, because I'm a physician scientist. I'm a pediatric oncology doctor, so I take care of kids with cancer. I primarily run early phase trials for people who have limited options. How does systemic racism actually affect our practices? Well, there are a number of patient-reported barriers to clinical trial participation, and this is evidence-based, and I've compiled them. This is from a study out of the NIH. So for one, there are some that are clinical trial design related. So there's some discomfort with randomization, placebos. A lot of these trials have very complex or stringent study requirements, and there's often a misconception that trials are not appropriate for serious illness. In some situations, such as patients that I take care of, trials are often the only hope for these patients. And there's an underlying general discomfort with the research process. Patient-related, lack of awareness, limited knowledge, fear, suspicion, and mistrust, often deeply rooted and with good cause. Lower socioeconomic status and poor health literacy. Logistical, lack of transportation, financial burden, interference with work and family responsibility, burdensome procedures, out-of-pocket expenses that augment the costs that are not necessarily covered by an insurance company. And then physician-related, and I want to focus on this because often Black and brown patients are considered for trials at a much more advanced stage than a white patient. Minorities are less likely to be invited, sometimes due to physician bias. This includes perception that they would be less likely to meet stringent eligibility criteria. Again, this is this ability to cooperate. This quote says it all. Access, not willingness, is where the difficulty lies in recruiting and maintaining minority research participants. When we look at a root cause analysis of clinical trial access, minority patients are often less likely to enroll on clinical trials, often that would be beneficial for them, and often clinical trials that study a drug that is not available to them outside of the trial. Why is this? Well, the trials are often less accessible to minority patients, and we discuss some of the real and perceived barriers. And why? Financial hardships. Perception of experimentation, and this is real. If you are a scientist, if you are a nurse, if you are a healthcare professional, you should familiarize yourself with the Tuskegee experiment, with Henrietta Lacks and HeLa cells, because it is real. Limited physician engagement beyond academic medical centers and disconnect with study personnel. Well, why? Because the barriers are often not well recognized by study personnel. These need to be addressed at study conception. Why? Well, the focus is often predominantly on science and less on psychosocial barriers. And the why to that is there's a lack of money, there's a lack of early engagement, and there's often a lack of personnel with the knowledge and the access to these resources. So what can we actually do? We've talked a lot about a lot of problems. Let's talk about some solutions. So some simple countermeasures. We can ensure that race data exists on the impact of diseases such as with COVID-19. This can help inform policy regarding health resources. For example, in the sense of COVID, testing in areas that are predominantly Black and brown, relief funding, careful consideration of specific barriers up front. This can lead to planning this into your budget when you're planning for a grant or for a study. Engage social work. Ensure the clinical staff is representative of the population. I'm very big on the pipeline and the streamline of Black and brown physicians, scientists, nurses, healthcare workers. Ability to proactively address common misconceptions and communication barriers. It may be much easier for me to address misconceptions without my patient even saying them to me because I understand them. Equity considerations for immigrant and mixed documentation status families, which helps to foster trust, early intervention, and feasible risk mitigation. And lastly, using non-traditional recruitment methods that involve community engagement, community centers, churches. This allows early discussion of potential trials and barriers prior to the consent process. So I'm going to end talking about a personal story, and this is one story, one of many, and I've been given permission to share this story. This is Granny, and as you can see here, Granny, who is my childhood best friend's grandmother, is looking just as fabulous as she always does. So Granny, like many Houstonians, was infected with COVID-19 about 6 weeks ago. When Granny presented to the hospital, she was having difficulty breathing. She was placed on this non-rebreather mask. And initially, her family called me and they said, well, we want her to receive additional care and be placed on the ventilator, but the doctors aren't sure that they want to do that. They asked me to intervene, and when I spoke to the doctors, they said, well, we didn't think that they would actually want that. I said, well, why did you think that they would not want that? Did you ask them that? Well, we just thought that perhaps they wouldn't want it without additional explanation. Granny was placed on the mechanical ventilator. This is her FaceTiming with her daughter, and she was on the ventilator for a couple of weeks. During that time, I spoke to the doctors at the hospital as an advocate for the family about every day, and I kept asking about a tracheostomy, because they were having a lot of difficulty actually ventilating Granny. And my friend, they noticed that a number of other patients in the unit had trachs. And I asked, why was she not considered for a trach? And the doctor said, well, because of her other medical problems, we didn't think it would be appropriate. I said, well, what other medical problems? And they could not name one. Granny got her trach after a number of calls for me and escalations. And fortunately, she is at a rehab and she is doing much better today. I want to point this story out because I play this role in a number of my Black and brown friends and family members who are not in the medical field at least 3 to 4 times a week. And I suspect that many of you play this role as well. So this is a prime example of implicit bias and assumptions that were not discussed with the family. So I'll stop with some recent quotes that I think are worth marinating on. I won't read them out to you because you will get a copy of these slides, but they really have stuck with me. I will actually read this last one because Professor Eddie S. Claude said this the other day and it really struck me. We are trapped in this fantasy of America that does not want to be responsible. Once we tell the truth about who we are, we can free ourselves into imagining things differently. Every time we try to give birth to a new nation, the umbilical cord of white supremacy is wrapped around its neck. So we have to be truthful and really be responsible midwives so that we can give birth finally to a new country that is a genuinely multiracial democracy. And I have my information here. I'm happy to answer questions at the end. Thank you guys so much.
Great. Thank you so much for that, Rayne. That was fantastic. Really appreciated hearing from you. As always, great presentation. So we're going to move forward and go ahead and bring on, have Dr. Stacy Lloyd go ahead and give her presentation if you want to share your slides.
Awesome. Okay. All right. Good afternoon, evening, technically, to everyone. I thank you all so much for this opportunity to speak with you. When I saw Dr. Kamara Jones was here 2 weeks ago, I was completely elated because I've had the opportunity to see her speak in person before. I hosted a conference a couple of years ago that she was the keynote speaker at, and she is absolutely phenomenal. So I know you all enjoyed that, and I consider it an honor and a privilege to be considered on a similar platform that she was on as well. So I want to talk to you today about racism in research and why cancer disparities continue to persist. This actually is very important to me, not only because it's what I do, but because it's also a struggle of mine, and it's something that I'm constantly fighting for in the lab every single day. So I started in this field of cancer disparities because this is what I saw. If you looked at, it seemed like, and I remember being an undergraduate student, and in my personal statement for graduate school, I remember saying, what is it about being Black that causes you to be predisposed to get every single disease on the planet and die of it first before anyone else? And that is really what I went to graduate school to understand. And so as time has gone on, that trend has not changed. So if you look at pancreatic cancer, breast cancer, prostate cancer, lung cancer, these are all mortality rates, and this is from 1975 to 2017. And you can see that over all this time, not much has changed. These are decades long issues. Like, we've known this for generations after generations. It's not as if there was a time where this data didn't exist and we didn't know what to do. It's always been there. But it took literally until the year 2000, and actually, ironically, that's when I graduated high school, when the Minority Health and Health Disparities Research and Education Act actually established for the first time the National Center on Minority Health and Health Disparities at the NIH. And it actually provided a clear mandate of leading and coordinating biomedical research on minority communities. That just happened. Literally, I graduated high school in 2000. And it was interesting because as I was going back and looking at this from a historical perspective, I actually pulled this information from the paper of the first summit. The NIH held its first summit in 2008 on health disparities. And I was at that summit. And I remember them telling me that it was the first time that they had done it. And at the time, my brain couldn't conceive how in 2008, the NIH was just now doing something about this. But, you know, that's where we were. And that's what has happened. But since that time, one of the things that was very problematic is this mandate was made, but there was never a general consensus on two things. One of which is listed here, and that was how to quantitatively measure these differences that we had been seeing for so long. The other one we never did come to a consensus with is what actually disparities meant and how to define it. And that's why now you will hear the term disparities, but just as frequently you will hear the term inequities. And there is an ongoing argument that whether these are the same or whether they're different. However, that's a lecture for another day. But because there's never been a general consensus on how to quantitatively measure these differences, what we ended up with is decades upon decades and thousands upon thousands of scientifically sound, notice I said scientifically sound, thorough research studies that were wrought with implicit and unconscious bias. And I'm going to present, the rest of this presentation is going to be presenting you an example. And this is one paper. I do not know these authors. I don't know any of them, but this is one paper that I found that is, in terms of scientific feasibility, integrity, scientific method, it is completely sound. Like, they did everything that as scientists we are taught to do in our papers. And they did it. They did all of it. However, if you notice, their entire paper is all about looking at specific gene expression patterns for aggressive prostate cancer in African American men. And just like anyone that's wanting to do disparities research, whether you're specifically targeting African American populations or Hispanic populations or Native American populations, we have this thing where we think it's a great idea to compare populations. And so that's exactly how they start. And these are direct quotes from their paper, where we initiated our study by retrieving microarray data of 619 patients, 412 African American, 207 Caucasians, and where they came from, everything. 362 transcripts were differentially expressed. So they report all of these differences, okay? This is one of their next figures. They utilize both immortalized non-tumorigenic RWPE1. If you do prostate cancer research at all, you know these cell lines. These are established cell lines. They've been validated. They've been in the literature, written about hundreds of thousands of times. For the most part, they've all been relatively fully characterized, okay? And again, they're taking Caucasian or European American cancer cell lines, and again, comparing them to African American derived cell lines. And as you can see with this great figure on the side, they've even gone so far as to look at, you know, differences between race at the level of the tumor, at the level of normal tissue, okay? And then I believe at one point they also subtracted out the effect, because we know prostate cancer can have a field effect. So they've even gone and subtracted out the effect of that normal tissue on the expression patterns. So, I mean, just excellent, excellent paper. They moved on, and they even validated this again in FFPE prostate cancer tissues. Again, comparing 39 African American to Caucasian patients. Again, everything that we are taught to do in the lab on how to publish a paper, validation upon validation upon validation. And so in the end, they conclude, in this report, we established a sharp contrast between the expression patterns of African American and Caucasian prostate cancer patients, analyzing microarray data from this geodatabase, and we goes on and on and on. And again, I say, they did everything scientifically correct. So what's the issue? The disconnects have always been the assumption of using European Americans as a reference group. That's always a significant issue, because it creates this unsaid superiority, because you're comparing your variant versus a normal or a standard. So from a scientific perspective, you can somewhat understand that, because we know European Americans do present with a less aggressive phenotype than do African Americans. The Human Genome Project taught us that African Americans, or patients of African origin, have a much more greater genetic diversity than European Americans, okay? So there are some things that we can begin to understand. However, what we must always understand is that race is a social construct. There is no biological emphasis or biological understanding for race as a concept, because do know that race was developed from the rule of hypodescent, or the one-drop rule, which was used widely across the South, in large part to subjugate mixed race heirs from legally receiving their respective inheritance. So I'm originally from Louisiana, so I know this a bit all too well. So what would happen is, when a slave master would impregnate a slave, that child that was born would have every right. I mean, that happens even today. If one of your parents was to pass and they had another child, that child has the exact same rights to any heired property that is passed on. Well, this rule was developed so that mixed race child would under this rule would be considered Black. Therefore, they had no legal right to anything. So it was a way of continually separating Blacks from whites, and keeping that inferior status, or that subjugated status, upon African Americans. And so one of the things is, we have to be careful when we're making these types of assumptions, because one thing that I've always said is, when you're studying cancer, there's never a such thing as a quote unquote normal cancer, period. So when you're doing these types of research studies and these types of projects, you really have to be careful about what and who you are considering as your quote unquote reference group, and ensuring that that quote unquote reference is absolutely comparable as much as possible to the group that you're actually studying. The next disconnect is biospecimen use and lack of verification. This is a study that I published along with a mentor of mine, Dr. Rick Kittles, who actually was the inventor of African ancestry and the ancestry typing, okay? And we found, and we knew this, I discovered this, I moved to Baylor in 2013. So I actually found this out probably the end of 2013 going into 2014. We had we were told was an African American prostate cancer cell line in the lab, E006AA. I was told that that was an African American prostate cancer cell line. Well, I'm a scientist, so I check everything. So I sent it to MD Anderson to be STR typed, and I sent it to my mentor, Rick. Make sure this is what they tell me that it is. And it was not. E006AA is a white renal cancer cell line. It is not an African American prostate cancer cell line. However, in this paper and in many other papers to this day, that cell line is still being utilized to make generalizations about African American prostate cancer. That, to me, is just despicable. And it's ironic because as I was putting this together, I came upon a paper that used E0, and this was a 2020 publication, that used that E006AA cell line and stated that ATCC, and I didn't realize this until they said it, but ATCC has listed on their website that it has the exact same profile. The STR profile of that E006AA has the exact same profile as a renal cancer cell line. The author put it in the paper, but yet she still drew her conclusions that it was an African American prostate cancer cell line. That to me is just scientific malfeasance on every level possible. But until I presume the NIH or others began to really take this seriously and understand the true implications of what they're doing, then maybe it doesn't mean much. But at the end of the day, what you have to understand is you are doing research that is designed to affect and change the lives of human people. You cannot look at specimens or samples. Even they can be as blind as they can be. You may not have ever touched the human that it came from, but it came from a human being and it will reflect on a human being. And this is where the issues continue to arise. So the last disconnect that I've listed for you today, because I want to make sure I don't take up too much time and we have plenty of time for questions and Q&A, is that there's no context. One of the things that I always teach my students is that disparities work of every kind must be done in context. Because especially, and I do the biological work of disparities. And so at the end of the day, if you do not provide the appropriate context for your research, you're left to answer only one or two questions. And that is, do we really believe that African Americans are biologically different from other racial and ethnic groups? Or just the majority group, if that's who you're comparing? Are they really biologically different? Or do we believe that African Americans live a different experience from the majority? And it's that difference, it's that lived experience difference that induces biological changes. And so depending on what you believe will truly dictate how you do your research. And if you believe the latter, which is what I believe, You will design experiments that will elucidate or account for, in some capacity, the lived experience of the African American or the non-majority group, whoever it is that you are investigating. You know, I do not believe with any reason that you have to do cross-racial comparisons to do disparities work. But people believe that. And I know people believe that because I've been told that. Well, Stacy, if we don't compare African Americans to European Americans or to whites, it's not disparities research. And that's not true. Okay? Because at the end of the day, disparities or inequities is a social justice issue. So that's why your context of your research is important. Okay? So I believe it's perfectly okay to have a population that's nothing but African Americans. African Americans from different regions, from different locations, that come from different social classes. The other caveat is ensure the accuracy of your biospecimen. If you are going to be making conclusions about a population of people, make sure that the samples that you're using reflect at least one person in that population. Because do know that that sample that you're using is truly only one person. HeLa cells, as much as they double, they all came from the one Henrietta Lacks, and that's it. The next thing is I always encourage, and I know this is difficult, and I have experienced this difficulty with being at Baylor, and that's learning and being able to integrate social and environmental barriers or variables or social structures. That can be particularly difficult, especially within a basic science institution like Baylor is, because one of the things that I've realized is as basic scientists, most people just don't collect that level of data. But you can start because that will help you create and give context to your work. Because it's one thing to say that African Americans have more prostate cancer than European Americans do, but it's another thing if you say one of the reasons African Americans have more prostate cancer than European Americans do is because of X variable, dietary factors, environmental factors, exposure factors. You've got to give it some kind of context, or else you're left with, again, that subjugation that there is a biological difference between this population and that population. When at the end of the day, we all know there is but one race. We all just come out looking a little bit different. And so I close with a picture of my family. Rayne, I was tickled because I don't necessarily have a personal story, but I love to close or at some point show my family because, like I said, I'm from Louisiana. And so my family runs the gamut in terms of complexion, in terms of hair texture, in terms of body type and style. And this is just a few, okay? So this concept that you can look at a person and tell what they are, or just solely go by the self-reported race, because a lot of times that's what we use as well. There are too many resources available today to continue to conduct research blindly. Some of the things that we do must be blinded, but we have STR typing, we have ancestry typing, we have so many ways to validate our studies. If you want to get into biological basis, you have to do your due diligence to ensure that the conclusions that you are making are valid and sound all the way around. So with that, I'm going to close, and I look forward to your questions at the end.
Great, thank you so much. That was fantastic. Look forward to asking y'all more questions as we move forward to the Q&A. And finally, I'd like to hand it over to Dr. Renata Nero, who will finally close us out with our final presentation before we go to the moderated Q&A.
All right, I'm going to go ahead and get started. And I would like to, again, thank you so much for the invitation to speak to this auspicious group this evening. And I'd also like to just really commend the previous presenters, because the information you provided was just absolutely fantastic. And I want to talk about what it means from a psychological perspective when it comes to disparities and when it comes to the treatment of African American clients, as well as the training of African American psychotherapists, and to kind of point out how there is quite a bit of similarity. So let me go back to the original slide. Okay, I'm gonna just, all right, see if I can go back. Let me just end this and take it all the way back up here. Okay. So I want to start with talking about a textbook that I actually used back when I was in college. And I'm going to try this again. And the name of the textbook was A Historical View of Psychology, and the name of the book was Even the Rat Was White. And that should tell you quite a bit about what was discussed in the book. Sorry, I can't get back to that one, but let me just explain to you what the book was about. The book talked about how the field of psychology has been especially noted for its scientific racism, and how the purpose of psychology was for the mental well-being and the mental health for Europeans. And in the field of psychology, the scientific racism that was present was there to legitimize as well as to reinforce beliefs about Black inferiority. And one of the most notable ways in which that was done was the role of psychological testing, especially IQ testing, when it comes to whether or not money should be spent in school districts to try to further programs in order to try to close the gap between Black and white students. There was always the research that indicated it doesn't matter how much money you spend, that this is something that is not likely to happen because these are differences that are genetic. The other thing that the book also talks about is how difference is viewed as pathology. So wherever there is a difference between, let's say, whites versus Blacks, that the difference is pathologized. And so the deficit model is quite common. And so that has been the history of psychology. And with the scientific racism, we also see that actually blending into the actual treatment of African American clients. So there may be certain therapies that are not actually afforded to African American clients. And for a while, the belief was that African American clients probably cannot benefit from insight-oriented therapy. And so that meant that the services that African American clients received were not just different, but of lower quality in many instances. And again, this was sort of perpetuated that this is just what to expect when it comes to treating African American clients. The other thing that I wanted to share had to do with psychology, yes, has been especially noted for the scientific racism, but this scientific racism is actually quite pervasive. And as my colleagues before me indicated, that is certainly seen in medicine, and it is certainly seen in the field of psychology, and the way in which you see it across different disciplines is that, again, deficits are considered to be something that can be pathologized. So when it comes to what is currently happening with scientific racism, with again, African Americans maybe less likely to receive quality care. This was happening before the current pandemic, and now it has been amplified. It has been further exacerbated to the point where we have an urgent situation. It is now urgent. The American Psychological Association says that we are experiencing the collision of 3 national crises: the COVID-19 pandemic, economic turmoil, and recent traumatic events related to systemic racism. As a result, the collective mental health of the American public has endured one devastating blow after another, the long-term effects of which many people will struggle for years to come. We don't have to be passive players in mitigating the rapidly increasing stress Americans are facing and its consequences on our health. And so the operative word here is passive. It's very important that we act, and so there is an urgency here. Statistically speaking, the American Psychological Association has found that there is actually a 13% increase in African Americans reporting additional stress due to discrimination. And this 13% increase actually coincides with the murder of George Floyd. So 1 month in, they began noticing that African Americans are reporting additional stress. And this is on top of stress that they may have been experiencing previously. The other thing, from an article on June 22nd from the New York Times, there was also a report that more white Americans are now realizing that racism really does exist and that racism is extremely pervasive throughout society. We're hearing less of the post-racial narrative. And so there's more of a realization that racism is real. And so we also have a convergence of a pandemic and people becoming more aware that this social justice issue has to be addressed. And the sense that we are not free until everyone is free, and more people are realizing Black Lives Matter. Black Lives Matter.
Do you know if your slides are advancing? We're, I think, still on the why the urgency slide.
Okay, so let me see. I may have to advance it manually. Okay, all right, thank you. Thank you for that. Okay, so one of the things that I mentioned earlier is that the pervasiveness of the sense that this is pretty much across the board. And I really like a quote from Dr. Ibram X. Kendi in the book Stamped from the Beginning. In that book, he talks about the idea of the inequality of white and Black races, and he believes that that was stamped from the beginning, and that this is something that is immutable, it's just there. And this is a type of sentiment that also fosters some of the beliefs that professionals may have when it comes to working with African Americans, and that they may not provide the best services, or they may not even engage in services that have been found to be effective, because there is a sense that, what can you do? These differences are immutable, and you really can't, they really cannot be changed. That is in the DNA. And so briefly, I'll discuss statistics on disparities, define some key terms, talk about some implications for African Americans seeking services, implications for African American trainees, and what the evidence suggests, and then do a brief summary. One of the ways to begin to reverse the trend of African Americans receiving lower quality of care, to also begin to reverse the trend of African Americans feeling more comfortable to access services, to begin to reverse the trend of African Americans staying in therapy long enough for therapy to really be effective, is to have culturally competent counselors. So being able to increase the number of counselors who present or have the same characteristics as the client, that is one way of doing it. But even more important than that, it means to make sure that anyone who works with persons of color, that they take an active role in being aware of their own biases, that they take an active role in being aware of their assumptions and so forth, as these assumptions can determine whether or not a person is able to receive proper treatment. The other part of cultural competence is to try to understand a worldview that's different from one's own. There has been a tendency to push for assimilation and to have people be more the same. And again, this has to do with seeing differences as being a type of pathology. And so understanding that differences do not equate to pathology, and to understand worldviews, that is another way for persons to become culturally competent. And then the other thing is practicing appropriate, relevant strategies that actually work with an African American population. And those are some of the things that I'll be discussing. The other term that I wanted to define is the term anti-racism and what that means. And so being an anti-racist is someone who is an upstander. That means this is somebody who stands up for when things are actually wrong, when they see something that is not right. They are the opposite of a bystander, someone who just sees things and does nothing. So when it comes to being an upstander or someone who is anti-racist, it's important for institutions to promote an anti-racist stance. And so that means to object to racist jokes on the job as well as in one's personal life. It means trying to educate family, friends, neighbors, co-workers that racism is real. And it also means taking direct action when we see racism. So if it's in the schools, if it is within institutions, that if we see colleagues practicing racism, whether it's implicit bias or not, that we stand up and we say something and we do something. And so earlier, the indication was one of the things that we have an opportunity to do right now is to not be passive and to actually take action. When it comes to actual disparities, one of the interesting things about mental illness is that it's found that the incidence of mental illness is pretty much similar across the board. You know, there may be a few percentage points difference when it comes to incidence, but the likelihood of a person experiencing certain mental illnesses, that seems to be kind of across the board, but the utilization of services is very different. So for whites, you see that whites are far more likely to utilize psychotherapy services, and whereas African Americans or Hispanics or members of the Latinx community, they're about the same, and then Asian Americans tend to have lower utilization. But whites tend to use psychotherapy services far more often, and one thing that is consistent, women are far more likely to use services than are men. And when it comes to people actually accessing services, there are a couple of things that I wanted to kind of point out in terms of whether or not the person will either access, and if they do, if they will stay. And so there's some things that make it difficult for some people to access, and that has to do with whether or not a person has insurance and the quality of the insurance. Another issue is that when it comes to actually going to therapy, depending on which statistics you read, it's either 1 out of 3 African Americans who need services will actually go in for therapy, and some say 1 in 4. It tends to be maybe even lower for the Latinx community. And then the other thing is that African Americans may be more likely to be seen as an inpatient, and this may speak to that some African Americans may not seek help until the problems become very serious. And so they're more likely to seek help later than sooner. But there are 2 things in particular that I want to focus on, and this has to do with African Americans receiving lack of quality care and African Americans leaving therapy prematurely. And so when it comes to lack of quality care, what this suggests is that there are some evidence-based practices that have been shown to be quite effective, but even though they've been shown to be effective, African American clients may not receive that care. There are some empirically supported relationship qualities that have been shown to be effective when working with African Americans, but those relationship qualities, either the therapist chooses not to use them, or the therapist may not be aware or be culturally competent to use them. And then the other thing has to do with African Americans being more likely to leave therapy before they've completed their goals. And some things that might contribute to leaving therapy could be not feeling as if the client and therapist have connected. And so it's called lack of a therapeutic alignment, lack of feeling as if the therapist really understands. And that could be that the therapist has not had a lot of exposure when it comes to working with African Americans, and that may show up in some ways in the therapy. There are some other barriers to care that's important for mental health professionals to be aware of, that within certain communities of color, there's still a stigma associated with mental illness, that having mental illness is seen as a form of weakness. And persons may also be encouraged to maybe talk to a person within the religious community before seeking a psychotherapist. There's also lack of providers from diverse racial ethnic backgrounds. When it comes to talking about racial issues in particular, there are some clients of color who prefer to talk to someone who shares certain characteristics, share a cultural background. There's a belief that if they have someone who's very similar to them, there are things they just don't have to explain. And then, as I indicated before, lack of insurance or underinsurance. There are two barriers to care that I'd like to particularly point out, and that has to do with distrust of the healthcare system. I think both Drs. Lloyd and Rouce mentioned distrust of the healthcare system. That goes back to instances of when African Americans have not been informed about the type of care that they would receive. They have not been given consent about the care that they were to receive. And then there's something called verbal dominance that can happen in a session with a provider. And with verbal dominance, that means the person is being talked at as opposed to talked to. And that means that that person is being far less client-centered than they would need to be in order to get the client's compliance. And then there's lack of culturally competent providers. And so these may be persons who practice in terms of a more ethic, from a more ethic position than opposed to an emic position. And so ethic means that there's a belief that all counseling is good counseling, all psychotherapy is good psychotherapy, that if it's good for one group, it's good for everyone. And it's been found that there are some cultural variables that need to be taken into consideration when working with persons of color. And so one of the things that is being promoted now is to work from a more emic perspective. And so that's a more culture-based perspective. And so from a culture-based perspective, a therapist would be far more sensitive when it comes to how much distance there is to be between the client and the therapist. They would be more sensitive to that. For some clients, it's important for you to look professional when you meet with them. That for some clients, if you're doing family therapy, it's always important to greet the male member of the family, the oldest male of the family first before greeting women. So there are certain things that you take into consideration in order to be less likely for the client to leave before the therapy is done. And there's some other things, and so just in terms of communication styles, and with African American clients in particular, there may be some communication styles that can make persons who are less exposed or who have had less exposure to African Americans uncomfortable. And so one of those styles might be prolonged eye contact when speaking, or not providing eye contact when being spoken to. And in psychotherapy in particular, one of the ways in which we make evaluations or assessments about people is whether or not they maintain eye contact. In some cultures, to actually have eye contact can be considered a sign of disrespect. And so that means that the therapist is going to need to kind of reevaluate the meaning of eye contact when it comes to one culture versus another. The other thing for African Americans in particular is that their style might be perceived as hostile or angry. And it is very easy for someone to maybe perceive an African American style as hostile and angry if they are not doing anything to try to ingratiate or to try to disarm someone of their guardedness. And so they might be perceived as angry or hostile. They also might be perceived as animated in their communication style, so using hand gestures, talking loudly, maybe even talking rapidly. Those are things that can also get things off on a bad footing when it comes to psychotherapy, using greater bodily movements. And for many African Americans, there's a belief in something called turn taking when it comes to a conversation, that they believe that it's important for them to be able to share or talk about what it is they need to say in a particular session, and they might interrupt the therapist. And so communication styles may also make it challenging for African Americans if they do not have a culturally competent therapist. So what about the trainee? Well, for the trainee, the same kind of insidious sort of message that Dr. Kendi talked about in his book, that still exists for trainees. So they may have been admitted into the graduate program, but there may be this kind of sense of this stamped from the beginning, that maybe this particular candidate doesn't have the same abilities as other candidates in the program, or maybe they don't have the same potential. Or maybe the reason why they're there is because of affirmative action and they had to check off a box. And so that is something that may sometimes be communicated to trainees that are in programs. And when this happens, something called stereotype threat can occur. So stereotype threat is confirming a false stereotype about oneself. And an example of stereotype threat would be if a student does not do well on the first test, then maybe they have confirmed this notion that they don't have the same ability level as someone else, or they may feel as if they've confirmed that in someone else's eyes. And so stereotype is real. And with stereotype threat, what can happen is that a person who actually has a lot of potential and actually could do very well, they may begin to do less well in a program. And so for trainers and people who bring in individuals into programs, to make sure that that students are encouraged, and that if they seem to have some sort of weakness, to help them to overcome it, because that may affect whether or not they feel comfortable staying in the program and their time in the program. And then the other thing for the trainee, there are several modes of adaptation in terms of how someone in a program, especially if they're in a program where they are in the they're in the minority role, there aren't that many people who look like them. They do have several ways in which they can show up, ways in which they can adapt. And so they can withdraw, they can separate themselves, they can assimilate. And so assimilate refers to they can sort of reject aspects of their own culture and just accept the dominant culture when they're in programs. But the type of adaptation that seems to be the most positive is the affirmative, or the affirmation way of showing up. And so with affirmation, that's when a person is able to pursue their goals in spite of what may be going on around them. They're going to affirm their worth, affirm that they are worthy to be within a particular program. They're going to affirm that they are moving towards their goal. And so they're going to do some things for themselves, and they will seek out people who will also do that for them. And so things like mentorship, that's very important when it comes to a trainee, being able to move through programs and not be affected by stereotypes others may have about them. And when it comes to clients, if there is an issue with disparities, having that client work with a culturally competent therapist, that is one of the ways to address disparities with clients. When it comes to African American clients, encouraging them to get help sooner rather than later. And this encouragement can come from family members, it can come from members of their church, it can come from friends, but to encourage the person to get help sooner than later is one of the ways to address disparities. And then developing a strong affirming identity. And this has to do with one's racial cultural identity. So knowing who one is, not allowing others to define who a person may be. All of these are things that can lead to a stronger identity. And then when it comes to African American clients, providing evidence-based therapy, that there are some therapies that have been found to be quite effective when it comes to working with African American clients. And for the trainee, becoming integrated and active in one's environment. And so withdrawing, and especially with withdrawal in particular, that one appears to be very detrimental to a person being able to do well within a program. So actively participating in the environment, that helps a person to move from trainee to professional. And then providing a safe environment that encourages trust. That's one way in which we can decrease disparities among African American clients. In a safe environment, the client can actually bring up those instances where he or she feels as if they're not being heard or they're not being listened to. And having the therapist to check in with the client to see how the therapy is going from their perspective, that's one way to encourage a safe environment. And then working towards positive changes for the trainee. If there is something within the program that the trainee feels needs to be corrected, they can work towards it. And a lot of it has to do with how he or she shows up. This is where something called emotional quotient comes into play. So there's EQ and there's IQ. It's been said that people with high EQs end up working for people with high EQs. And so emotional quotient means that people know how to regulate their emotions in such a way that they're able to communicate their needs and they're more likely to get cooperation. And so working on one's EQ can be a way to kind of work towards positive changes. So in summary, the profession of psychology has made great strides when it comes to dealing with disparities. The American Psychological Association comes out with reports on a regular basis in terms of what is happening within communities of color, how they're impacted by COVID, how they're impacted by cultural competence or lack thereof. So the profession has made great strides. However, the notion of how science has been used to maintain the status quo is still there. As a psychologist who's been trained to do testing, I am responsible for how I interpret the results and how that impacts someone's life. So I have to be keenly aware that just by doing my job and doing my job without awareness can actually lead to persons not receiving the care that they need. And then the stamped from the beginning, that's part of our historical roots within the country. So this notion of disparities, that is across the board. We see it politically, economically, religion. We see it throughout society and education. That is just a part of society. And then when it comes to systemic racism, to kind of understand that it does impact how clients are treated, and it also impacts the training and preparation of future providers. And the thing that is actually promising is that people are now at a pivotal time in society where they are working collectively to address systemic racism, that there are more people who are adopting an anti-racist stance. And as we start moving in this direction, we're far more likely to move from mental illness to mental wellness.
Thank you, Dr. Nero.
You're welcome.
On behalf of everyone, I do want to thank all of our panelists, so Dr. Rouce, Dr. Lloyd, and Dr. Nero. Thank you so much for sharing your expertise and perspectives on racism in healthcare and science. We are incredibly grateful for your time and insight. And now Bailey will lead the Q&A discussion.
Great, let's go ahead and get started. Dr. Nero, if you could just stop sharing your screen as well.
Okay, yeah, let me get this out of here. Okay.
Perfect.
Stop sharing.
Great. So let me just, so that will all be here. Great. So our first question is for both Stacy and Rayne. So first, Stacy, how do we scientifically counter the idea that there are no biological differences between races? So for example, some people refer to genome-wide association studies that could show DNA-based differences between different populations that increase their susceptibility to certain diseases. For example, Ashkenazi Jews and cystic fibrosis. And Rayne, from a medical perspective, how do you counter the same claim that race, as opposed to racism, is an underlying risk for specific diseases or bad outcomes?
Stacy, I think you're.
Yep, I just realized I was muted. Okay, so first off, one of the things that we really have to be careful of, and this is where context is very important, is there is a difference between, so when the original Human Genome Project was done, they were looking at a very specific group of Africans out of Nigeria that they're called the Yoruba population. Okay, and so you're not totally incorrect. Those differences have been identified, but one of the things that you have to remember is when you're studying modern day African Americans and not pure Africans from the continent of Africa, that modern day African Americans are an extremely admixed population. Okay, so every human on this earth has the same A's, T's, C's, and G's. Like those don't change. Those will never change. What changes is the expression levels of those genes. And so what you have to ask yourself is, why do those expression levels change? One of the things that we do know is that the transatlantic slave trade, just that one instance, caused epigenetic alterations within those populations of people that suffered that immediate and those immediate descendants. That happened. What current African Americans today are struggling with are similar. The only difference is we don't know what the epigenetic changes today look like. But you're talking about generations upon generations of alterations that have taken place, not only from the transatlantic slave trade, but through slavery, through Jim Crow, through Reconstruction to today. And so, we have this notion in our heads that, oh, that was so long ago, but really it wasn't. My parents, who were born in the 50s in Louisiana, lived through Jim Crow. So any epigenetic changes that they experienced, I inherited. Period. So that change happens. So there is a difference. So when you're talking about these biological differences, that's why context is important, because we're not talking about biological differences that are inherited based upon my race of how I was born. Those biological differences were inherited to me based on my lived experience, based on my parents' lived experience. So that's why I say context is important. You have to make sure that when we're noting these differences, you don't want to give the underlying impression that that African Americans or members of the Latinx community or Native Americans are some abnormal form of human. It's not that we're a different type of human. It's not that we're a different species. It's that our lived experience on this earth has been different from the majority population. Heck, even different from Native Americans, even different from Hispanic communities. So that's the account that you want to look for. And that's why context is important.
Absolutely. I'll just piggyback on that because I think you put that beautifully. From a clinical perspective, these assumptions of biological predispositions can actually be more harmful than helpful. So what this means is that Black or Hispanic patients may be more likely and are often more likely to have diabetes or hypertension, but this is often because of social determinants of health, because of their context. So when you approach a patient that is Black or Hispanic, do you automatically assume if they present to the ER with some medical condition, or if they present and want to be tested for COVID, that they're at higher risk because they must have diabetes, because they likely don't eat proper food? So the point is that we can't allow these social determinants and contextual constraints to actually pepper the way we actually address, manage, treat, and give clinical options for our patients.
And if I can add just real quickly, that is the main reason why I am an extreme proponent of basic scientists. Really, if you don't want to do the social work or the behavioral work or the environmental work, don't do it. But collaborate with someone that does, to give your biological work a deeper depth and greater meaning. And that so it can truly change someone's life.
Great. And I guess following up on that a little bit further, one of our questions was asking, would it be beneficial to identify differences in susceptibility to disease between races to develop personalized therapy? So like personalized medicine type approaches. For example, if Black people could be predisposed to having a more aggressive form of prostate cancer or different types of disease. What are your thoughts on that?
So I'll start. I think that there are, we have to be careful about this. So obviously, there are a number of diseases so I'm a pediatric cancer doctor. So there are types of genetic mutations within the leukemia cells, predominantly of Hispanic patients that are often teenagers, that have more recently been linked to having a higher risk of relapse. This is not due to the fact that they are Hispanic, it's due to the fact that their cells have a certain mutation. In that situation, we're able to use targeted agents that can improve outcomes in these patients. Absolutely, we need to continue to study and learn as much as we can about any patient population who has worse outcomes, because what we may find is that there is a targetable mutation that we can look for. Does it mean that it's only in Hispanic patients? Absolutely not. Is it possible that it's more prominent in Hispanic patients? Absolutely. So in that situation, yes, we have to continue. And I'm a big proponent. I don't want anyone to think we're not proponents of ensuring diversity in clinical trials, in our studies, so that we can identify risk factors that may or may not be solely based on a genetic determinant, or may not be also based on something social or contextual.
Yeah, I would just add to that, my only hang up on the personalized medicine piece is the access. At the end of the day, I'm again, I came into this with a question of what is it about being Black that causes me to be predisposed to die of everything? So my first thought was the answer is in personalized medicine. And if we could just personalize everything to everyone, or at least to specific types of populations, then this world will be a better place. But the reality is, if we don't do the work today to ensure that whatever work that we do, that it actually gets to those that need it, then it's still pointless and purposeless. So I am a proponent. I agree 100% with Dr. Rouce completely. But my caveat is just making sure that the access is absolutely there so that those populations do benefit from it.
Yeah, and I'll just briefly say that when we talk about personalized medicine, people also often assume that that means personalized for this patient's cancer. When we found this mutation, it was not because researchers were looking at why do these Hispanic patients do worse. It's because they were looking at these actual mutations and then retrospectively found, wow, this mutation happens to be more dominant in Hispanic patients. So when I discuss personalized medicine, it often means personalized to a mutation, not to a person. Then if we have access, if we include patients of all ethnic diversities in not only screening clinical trials, biological sample clinical trials, as well as actual treatment clinical trials, then we can move backwards and make sure that these same patients who have this BCR-ABL mutation, for example, have access regardless of what their race is.
Fantastic. Thanks for that great answer to that question. Okay, so this question is for Dr. Nero. So have you looked at data of mental health needs or usage and stratified it within race and using some of Dr. Lloyd's markers like zip code, income, etc., and seen more of a more striking difference there? Or made comparisons between statuses and race and ethnicities, like do white people from lower income statuses require or use more than Black people from a higher economic status?
Okay. I would like to say this is there is something called intersectionality, and it is extremely important not to view any group monolithically. And so for some groups, or for some persons, just based upon their educational level, their income level, where they grew up in terms of small town, north, south, it could be that this person might identify more based upon what's considered to be middle class white types of values than what one might consider to be more, what's considered to be more more African American. So it just depends, and so it is complex. It is complex. However, one thing that appears to be the case is that when it comes to certain relationship variables, it has been found that there are certain things that tend to be effective across the board. And so one of the relationship variables, supporting relationship variables, can be warmth. Another one is genuineness, how genuine the therapist is, regardless of what his or her race may be. Another one is how credible is the therapist and how trustworthy is the therapist. And the interesting thing about those variables is that it is very difficult to train anybody to be those types of things. It's very difficult to train someone to be those types of things. It's easier to make people aware of certain cultural competence types of variables and to help them to be aware of things that the client might express. But in terms of looking at if there are certain kinds of markers that might kind of identify, where culture might come in terms of working with the client, there's some things we don't know until we have that person in the room with us. And then we have to kind of make a call in terms of what is important. And then the other thing is that if we don't know specifically, we can always have the client serve as what's called a culture broker. And there are clients who will kind of share with us what they find to be effective and what they find to not be so effective. And so we have a safe enough environment for clients to feel comfortable doing that, then we've really made an impact.
Awesome. Thank you very much. That was really insightful. So this is a question for any of you. Feel free to answer. So considering the abuse of African Americans by the scientific community and the lack of representation of African Americans in clinical trials testing many of the drugs on the market today, how do we reconcile recommending medications to African Americans that have not been tested on people with their backgrounds, particularly in regards to drugs with known variable effects? And how can we address the distrust of Black Americans with regards to healthcare, especially when many health disparities are still being upheld by those same healthcare systems?
So I can start from a clinical trial perspective. So when you register a clinical trial, whether it be a phase 1, phase 2, phase 3 clinical trial, you have to go through, depending on what the trial is about, you have to go through a number of regulatory agencies that are responsible for ensuring that you have represented, that you either are ensuring that you are enrolling all races and ethnicities, and if you are not planning to, you have a distinct reason why you are not. The Institutional Review Board, which I serve on at Baylor, so every trial that goes through has to go through an Institutional Review Board, and there are specific people who are poised there not just to review the science or the medicine, but also to ensure that it is an equitable trial. What I will say is that now when you submit a grant to the NIH or most funding agencies, you have to, in addition to rigor and reproducibility, you have to ensure that you are accounting for any potential differences. It is not that most drugs or new products are not tested on people of various backgrounds. It's that the likelihood, like if you look at some of the PD-1 inhibitors that we see commercials about all the time with people running through fields because it's changed lives and lengthens people's life with terrible cancers, the majority of the initial studies were performed in white patients, despite the fact that in kidney cancer, for example, is a predominantly Black patient disease. Before you receive approval to move to the next step, you typically do have to reconcile these things. So what I would say is that for almost any clinical recommendation that you make, you can find where it has been tested in Black people, in Hispanic people, and there typically is not an understood biologic difference that we would expect in those patients. I get asked this all the time because I do immunotherapy trials where I take cells from a patient's body, genetically modify them, and put them back in the patient. And Black patients ask me all the time, have you treated any other Black patients? Hispanic patients ask me, have you treated any other Hispanic patients? And I'm able to discuss this with them. I think that the key is that the physician or the healthcare professional who is discussing the trial needs to actually think about these things and ask that question so that they can research it, so that they have an answer. And if they don't have the data, they can explain why they don't think that race would necessarily factor in to why that patient might respond differently. I'll quickly answer there are a couple of other questions because it's linked to this about inclusion criteria on trials, and whether, considering the fact that sometimes it's more difficult for minority populations because of other pre-existing health conditions to go on to investigational clinical trials. What we have to do as researchers who write trials is implore each other to really delve into why you have diabetes as an exclusion criteria. Do you expect that your trial is going to have a different outcome in someone with diabetes? And if the answer is no, why are you excluding that patient? So really it's something that we have to do as physicians, as scientists in the early stages of trial development so that we don't meet these roadblocks later. And I'll stop there.
I think she did great. I don't have anything to add.
Awesome. That's totally okay. So another question is, how do we explain from a scientific perspective that intergenerational trauma and oppression manifests into genetic alterations in populations that select over time, including for mental health issues, which are stigmatized as, quote, pseudoscience, unrelated to genetics or physiology?
So who are we explaining this to? Because my personal my personal belief is you tailor your message to who you're talking to. So I know that principally everyone here, at least not the people on Facebook Live, but principally everyone here is a trainee of some sort. You're in a graduate or medical program. These are things that you know. If I'm trying to explain that to a lay person, that's going to be a different answer.
Yeah, so I think the question was getting at like addressing that towards a layperson or someone who, like a white person who wouldn't necessarily think about, you know.
Gotcha. Oh, that's a good question. Okay. Yeah, I have to think about that a different way now. I think one of the things that I would definitely get people to understand, I think one of the big things is to get away, like I said earlier, get away from this notion that slavery was a long time ago, you know, because we're not talking about just slavery. You know, we're talking about a historical trauma that has gone on for generations, and just accepting and understanding of the fact that that there have been traumas, and that there have been issues that change the way my body, or you know, some African Americans bodies or Hispanic bodies or whomever the populations that you're talking about, that underrepresented person, that our bodies responds. I mean, it's as simple as you know, you could maybe even compare it to like metabolism, honestly, because we all don't burn fat the same way, we all don't process foods the same way. You know, we all do. Our bodies are all individually different. But if you're wanting to look at this from a population perspective, you know, I would explain it that way, and getting people to understand that, you know, minority communities are no different than your own communities. But the difference is, you know, minority communities have dealt with issues that cause their bodies to respond differently to things that your body may not respond to. You know, I can go to the gym, you know, we have, and Dr. Nero talked about these negative stereotypes, you know, and, you know, getting people to really kind of wrap their head around some of the beliefs that we've held for so long as true are really false. But the key first is, and what I always teach to my students is that before anything, you have to have an open mind and be able to be ready to receive that information. You know, that's another thing. You also have to make sure that the person that you're talking to is desiring to receive that information, because everyone doesn't want to receive it, you know. And if a person doesn't want to receive it, you can explain it. I'm like a preacher on Sunday morning, but if they're not wanting to really receive the information, they won't. You know, so I would say you have to kind of take that into consideration too. People that are willing to learn will be open, you know, but don't waste your time trying to convince people that have no desire to change. I'll add that.
Great. No, that was definitely an awesome answer. I think you're definitely right. It's, to a certain point, people have to be open and willing to listen and actually come and understand where these other people are coming from. So next, we're going to kind of merge two questions together. So one attendee asked, as a Black trainee who seeks to be active in a suppressive environment, how do I keep from getting burned out from fighting systemic racism while maintaining high functionality as a scientist or a doctor in training? And I see a few of you chuckling, so I don't know if you want to go ahead and answer that part, and then we can put the second part in afterwards if you want, or I can do it either way.
Woo! All I can say is, I know. You and I'm laughing, but it's really a serious matter.
You're laughing so you don't cry.
Exactly. You know, because the truth is we've all been there. I will share a personal brief story. I suffered a stroke. My carotid artery ruptured at the end of 2017, behind stress and everything. So the reality is you have to protect yourself. And I know it's hard. I remember just finishing my PhD and being at a conference, and a student asked the exact same question to a panel of a bunch of senior scientists, and the answers just went everywhere except to the point. And you know, the reality is you first have to protect yourself, and you have to get a network. You have to. And if your network is not where you are, that's okay. And sometimes that can even be better. It doesn't necessarily make things easier every day when you go to work and you show up to the lab. It doesn't. And I can tell you, because I've been there, done that. But you have to find a network. You have to find an outlet. You have to find a safe place. And it can be in your church, it can be in a sorority, fraternity, it can be at a friend's house, wherever it is. But you have to find a safe space where you can just and just get all of that out, literally, because you hold it in. And I can tell you this because I did that. I am a holder inner kind of person. I am an extrovert because I'm forced to be, but I'm a natural introvert. So when it comes to, you know, traumas and issues and all the things that I had gone through, it just, you know, trying to get my PhD, all of that was still pushed down inside. And so when the stress level got to a point where literally, you know, I was going to the gym every day thinking I was taking my stress out on the gym, and I wasn't. I don't know, somewhere it just popped the carotid artery and bam, there was a stroke, you know. So I say that to say you have to get an outlet. Dr. Nero's here talking about mental health. That is of vital importance. I wish I had taken the time to talk to someone earlier. I didn't start getting on somebody's couch until post-stroke, you know. But if I had done that much sooner, like when I was going through my PhD and I was told that I should just be satisfied with my master's, that I wasn't PhD quality, you know, I was told that, you know. So if I had gone and sat on somebody's couch back then, I may not have, you know, suffered the stroke that I did. So I say this because I know where you are, but that's the one thing. Those are the few things I can say that I would do. Take your mental health serious, go talk to somebody, find you a safe place, and get a network.
And let me say something quickly, because I do want Dr. Nero, as the true professional here, to weigh in on this. One thing I will say, Stacy and I are both obviously outspoken people who you can see that we often carry the world and the plight of everyone on our backs. Many of you on here are likely the same. I had to learn the art of self-preservation, and what that means is every battle does not have to be mine to fight, because I have to preserve myself, because there are some battles that no one else will be willing or capable to fight. I also had to learn sometimes you have to tag other people in. And you students, you are so amazing. Your generation, you are advocates, you are activists. Do not get in a situation where you are putting your education and your career on the line because of a situation where people may not ultimately have your back. And that is sad to say, but that's a part of self-preservation. That's when you have to tag in people who may be a bit more advanced, may have a platform, who can also voice on your behalf. And I'll stop there.
You guys have given fantastic advice. I like what you said about getting help sooner than later. So get the help sooner rather than later. It is going to be important for you to find safe people. There may be people who are willing to talk, but they may not be safe. So if it is someone who is going to somehow kind of fan the flames a little bit and say things like, well, I wouldn't put up with that if I were you. In fact, I'd go back and And so that's not necessarily a safe person. So I would encourage that, and of course, to be able to talk to a therapist about what you may be going through, because that gives you a chance to kind of process some things. Self-care is extremely important, that there may be a tendency or there may be some laxity in terms of how we might care for ourselves during that time, but self-care becomes even more important when undergoing that type of stress, especially if there is some unfairness involved, if there's a feeling that you are being targeted or kind of singled out, and if you have tried to address it and you were pretty much ignored. No one saw it as a big deal. And there is something that is called like a catch-22. And this is something that students of color are likely to experience. The catch-22 is that you ask yourself, do I say something? If you say something and it gets even worse, then you're going to regret that you said it. Or if the other person makes it seem as if you're the one with the problem, it can make it worse. And so what happens is that when it comes to trainees or students of color, you have a much better perspective on reality, but the person over you is the one that gets to define it. And so you have to make a call as to whether or not it's important that you say something. And I want to encourage this young man, because there is something called post-traumatic growth, that not all trauma leads to a stress disorder, that there are people who actually grow and they actually become advocates, and they actually become people who are extremely resilient. So there's some growth. And one of my personal heroes is Nelson Mandela. And one of the stories about him is, of course, he was jailed in South Africa on Robben Island, and a cell that was barely 6 feet in width. And this is a man who's over 6 feet tall. And for many years, he actually was on the concrete floor of that prison cell. And he was also made to go out into this, where they had all these stones, and he was busting rocks. And there was a cave that he and the other prisoners had to use as a bathroom. But this is what Nelson Mandela did. Nelson Mandela used the cave as a university. He called it a university. And so these men who didn't know how to read or write, they were trained in history. They learned about all different types of subjects they never learned about in school. And when apartheid was finally over, some of them were actually part of his cabinet. And so one of the things that I'm going to encourage you to do, and this is how we get through crises, 3 things. You begin by reimagining. And so the way you're currently thinking about things, is important to kind of reimagine what you're working with. And then the other thing is to innovate. And so to be innovative and to think about maybe doing things differently. And then the third one is to pivot. And so you may be going in a direction, but you may need to turn a little bit. And so however that might be, but I do want to encourage you that even in a difficult time, there can be growth that comes from it. And so hang in there.
Awesome. All of those answers were amazing. I think, self-care is very important. And especially now during these times that are very wild and just like unprecedented with the pandemic and everything as well. So 2-parter on the back half of this question that we brought up before is another attendee brought up that along with combating structural racism for their community survival, people of color, especially women, manage their careers while taking on excessive diversity and inclusion leadership roles. They do community service, they serve as mentors, and they do much more, while their white colleagues do not deal with that burden. So is there any research studying how burnout negatively affects physical or mental health in people of color in academia or at any institution?
This is called the diversity or minority tax. It is a very common phenomenon of people of color often either being asked or expected to participate in diversity initiatives that they are passionate about. However, they often do not necessarily contribute to their ability to be promoted in an academic setting. So this is something that is very commonly known. And I'll be honest with you. I'm a physician scientist. When I first considered taking a role in the diversity office at Baylor, some of the more seasoned physician scientists and scientists who I'd met through study sections, through different grants that I've been a part of, were very hesitant, and they warned me about this. I think what was important to me to realize is that regardless of whether I have a position that says I'm in charge of this, I am always going to be trying to pay it forward to create a pipeline behind me, whether I have a title or whether I have partial salary support or not. So that was my personal decision, but I realized that I only could go after that after I achieved a certain status in my career. Had I delved as deeply as I wanted to into diversity initiatives earlier on, I likely would not have been as respected as a scientist, as a physician, because I would have spent a lot of time doing that. So that's my personal story. And what I would say to all of you is that, especially if you're a trainee, it does not, you have your whole career and your whole life to do things. So there will be times where being in the lab is what you need to do, where focusing on your studies is what you need to do. And throughout, there will be opportunities for you to give that don't necessarily make it impossible for you to excel in the structuralized manner in which you need to excel. I'll also say that there are a number of efforts more recently to ensure that diversity efforts, that there is a proper place for them on the CV for promotion, that there is a proper place for them, because this is a tax that often affects brown people more than white people.
That was an excellent answer. So I'm just gonna move along so we can keep answering more questions. So this is for Dr. Nero. So knowing how important therapy can be for graduate students nowadays, so should institutions be required to have providers from various backgrounds? Or should all providers be trained to be more culturally competent to ensure the needs of Black students are also met?
All right. So when you say providers, you mean these are providers that are at the university, or that there should be a network of providers that the university or that the institution provides?
I think they're addressing often mental health services that are offered.
Okay. Oh, okay. Mental health services that are actually offered.
So like,
okay,
having them have extra training, or should there be a more wide variety of representation?
Okay, that's a very good point, because when it comes to cultural competence, that's supposed to be a part of the curriculum. So that is something that is going to be a part of the curriculum for people who are providing the services. It's supposed to be. So for example, mental health professionals are required to get professional development in cultural competence, cultural diversity every year in order to maintain their license. And so the expectation is that people are getting the training, and that is something that is regulated by the state board. So it is important that they do that. And then so it is important that the institution lets the student know that culturally competent care is available, that it is certainly available, and that and to encourage students to be able to take advantage of it, with the understanding that it is in no way going to impact how they're viewed, how they're seen. So it should be something that is definitely encouraged. Now, on that note, if it is found that there's not a good fit between who is available and who is not, to see if the institution is willing to work with that student to find someone who is a better fit. And in that case, there are some great resources where people can turn to find people who are culturally competent. And so one would be NAMI, that's the National Association for Mental Illness. They have a website where you can go and you can find out about people who provide services, what type of mental health professional they are. You'll find out about their background. And there are questions to ask a mental health provider on the front end. And you can actually ask them, have you worked with someone from my cultural background before? How long have you worked with someone from my background? What was the outcome? And so you can actually interview a provider before you go in. And you can actually ask them those questions. So NAMI is a place to go. MHA, the Mental Health Association, they also have a resource list of where people can go and find competent and culturally competent providers in the event that you just find that the people who you maybe come in contact with, who might already be a part of the institution, it's just not working out. And so there's no need to stay in a therapy if the therapy is not meeting your needs. You've tried to address it with the therapist, it's not working. And so there's no need to stay in that situation because there are people out there who are quite competent.
Can I just ask Dr. Nero, in the event that a student, so for example, a student would typically go to student health services and there would be a couple, maybe two providers at best that they could choose from. If the student did not feel after either an initial meeting or consultation with the person that they would be able to meet their needs, are there ways where the institution, for example, could be provided with information such as what you've provided that could help augment, almost a contracting type situation? Have you seen anything like that, maybe even at HBU?
Okay, well, actually, students actually will report that I didn't feel as if this person understood me. And they actually can report that either within the clinic or if there is some sort of follow-up. And so if somebody just kind of drops out of therapy, there really should be a follow-up to kind of find out what happened that they did not stay with the therapy. And so that's actually kind of like almost like an exit interview, or you kind of check in. And at that point, that would be a good place for that person to say, I didn't feel as if this person really understood who I am as a cultural being, or I didn't feel as if I could really talk to them about things that were important to me because they may not have had the kind of life experiences where they could relate. And so it is going to be important that that feedback is provided. It's very important. And in an ideal world, it would be great if that person shared that with a therapist. I think you're a nice person, but I don't think we're connecting here.
Great. I just want to say for all that we received a lot of questions. So anything that we don't cover, we will definitely get to all the panelists and then they can answer them. And then we can post some of those answers to our link tree for later on in the future for everyone. Because a lot of these have been really great discussions and I don't want anyone to feel like their question's not going to get answered. So this is for all of you. An attendee asks, many doctors and healthcare providers still add African American to the descriptor of the chief complaint in a medical note. I've understood that that this addition was historically used to discriminate against African Americans, so do not use this and edit it out of my training notes. Can you please give your perspective about this?
I'll start on this. We were just discussing this, and Vicki knows this, and we were talking about curriculum, medical school curriculum, and how when you're presented with cases, for example, and it says a 64-year-old African-American female, a 15-year-old Asian male, and whether or not that descriptor is actually relevant to what you are presenting. And the historical, I think, use of these descriptors was often rooted in racism, but what has come out of it over the years and in medical training is that we do know that there are some predispositions, whether it be to epigenetics or whether it be to contexts that are more likely to be an issue in certain populations. So I think the main question is, why is it included? Even on the clinical skills tests for medical students, it will often, with standardized patients, there will often be a goal to have someone of a certain race or ethnicity because it's trying to trigger something in the mind of the practitioner to add to the differential. We can obviously all see, especially after today's discussion, why that can actually be more harmful than helpful. I opt to, especially when I'm working with medical students who are doing history and physicals, where they're writing them up and they're learning how to take a history and physical, I often will ask them if they include that information. Was there a reason that they did for this patient but did not for the white patient, or did not for the Asian patient? And if there is a reason that they're explaining, that they think that within their assessment and plan, they're going to actually address why they thought that was relevant, then that's one thing. I don't actively edit it out because I don't typically know the reason why the student or the trainee actually wrote it, but I do address it where I can. And I think that it's a bit controversial. And I think that it's worthwhile to look back at medical curriculum and look back at tests and understand whether it's really necessary or not.
Great. So that was a fantastic answer. We're going to do one more question and then we're going to wrap up, considering we've gone over a little over time, but I think it was really necessary to have all these answered and have this really great discussion. So this is the final question we have for y'all. There have been discussions of poor diet options in low socioeconomic status communities. However, when stores like Whole Foods or Trader Joe's move into communities lacking resources to healthy food, gentrification might occur, leading to potential displacement of low socioeconomic status individuals. What might be some solutions that, and how would they look like for providing quality food or healthcare to these communities without repercussions of something like gentrification?
Okay, I love this question because it kind of, it gets to, you know, my longer term goals. As a basic scientist, I mentioned this earlier, the key is collaborations. And so the reality is, as a scientist, the first thing that we have to show is that that issue exists. And we've done that to some degree, but that's number one, is we have to show that that issue exists. The second issue is you have to actually get in that community. Okay, you've got to get in that community. You have to get your face, like your actual face, not your institution, not, you know, you, the scientist. You have to get in those communities, show your face, do the research, but then you have to begin to collaborate with that community. And what we feel outsiders, and I will include myself as an outsider, as outsiders, we fail to see or empower the communities that we want to serve. You know, it's like, and I had a mentor that used to always say, you know, we don't want to be like helicopters where we fly in and fly out. So you go into the communities, you do the research, you do the needs assessments, you figure out what's happening, but I guarantee you there are people in those communities that can and have the power to change some of that. There are realtors in those communities. If the realtor isn't in the community, their family member is a realtor that will serve that community. There are urban developers in those communities. There are business owners in those communities. And if we would just take the time to empower the communities that we want to serve, we wouldn't have a lot of the issues of gentrification that we really do. You know, and that's one of the things that's very important is it's not enough in my, and this is out of the book of Stacy Lloyd, it's not enough to just do the research and show the evidence. That's great. And if that's all you want to do, cool. Call me once you're done and I will happily do the footwork, because that's what has to happen. Is the footwork has to be done to get into those communities, because one of the things that we don't do is we forget that there's power in these communities. You know, we think because they're quote unquote low income that they're completely disenfranchised. They don't know how to advocate for themselves. They don't know how to do this. They don't know how to do that. And the reality is, if you give them just a little bit of power, if you give them just a little bit of information, they will do the rest. A perfect example is that when I was at MD Anderson, a colleague of mine did some work out in Galena Park. Galena Park is out near the ship channel, and they had air pollution issues like crazy. I mean, just some major environmental pollutants just because of their location. And so what she did, she thought, and I was in the meetings and I was right there with her, that we were going to do this needs assessment, and we had planned in our heads all this work that we were going to do for them because they needed the help. The reality was, when we did that needs assessment, their needs were drastically different from what we thought as outsiders of what their actual needs were. We were concerned about cancer. They were concerned about asthma because of their kids. We never considered asthma. We're a cancer center. So of course, all we thought about was cancer, but they had asthma. They had obesity. You know, they had all these other issues that cancer was important to them, but it wasn't top of their list. So we had to go in with whoa, okay, now that we know what you all need, let's start ticking off y'all's needs assessments. And so it literally became us just being a resource to them. And that was it. We did our little research. We did our air samples. We did our soil samples. We did what we came to do. But at the end of the day, it was about getting the nurses and setting up community clinics within their schools so that their children could be treated for asthma. Setting up a pipeline so that way so if there was a crisis, that there was someone close enough to them and they didn't have to come all the way to the medical center to get treatment. You know, it's little things like that, you know, when you're outside looking in, we have these preconceived notions, but you've got to get in there to really figure out what is really going on and what really needs to be done. So again, directly to your question about the diet, as an outsider, I believe in some respects, you're totally right. But at the end of the day, once you get in that community and you empower that community, that dietary thing may not be as important. They may not mind. I have a friend that lives in 3rd Ward. Her closest grocery store is on freaking Alameda. She's got a job like 20 minutes to the grocery store. That's not her issue. That is not her complaint. She doesn't mind driving 20 minutes to the grocery store, you know, but she's got other issues that to her are more important, you know. So that's my take.
I think that was an absolutely perfect answer. And I don't have anything to add, except I'll just highlight what Stacy said about being a resource as opposed to necessarily being the savior. They're a very big difference.
Yeah, and I also want to piggyback on what both of you said. And what I liked was the social justice approach, in that as professionals, one of the things that will be required of us, especially now during the coronavirus, is to pivot in terms of our roles. And that our role is to also advocate at the micro level, you know, at the meso level, at the macro level, that in order for people to really receive the care that they need, it's going to be important for us to kind of step outside of what it is we may typically do in the office, and to also be very much a part of the community.
Wow, I think that was a really great way to kind of wrap this all up. I think we really had kind of a dream team here today to talk about a lot of these different issues. Everyone was able to address a lot of different questions that our attendees had, and I think it was really great. So I just want to thank all of you very much for all of your insightful talks and your answers to our questions this evening. To our attendees who are still around, please consider donating to our fundraiser so that we can continue to host webinars like this, as well as fund our advocacy initiatives across the Texas Medical Center. You can visit our GoFundMe page, which will be linked in the chat, or you can Venmo one of our organizers, her handle will also be in the chat. Be sure to follow our Twitter and Instagram. We have a Facebook page. And also to subscribe to our YouTube channel, where you can actually watch this whole seminar back and look at the slides and do all these other things. And we'll also be posting in our link tree that will have links to additional resources, our points of unity for MSCA, previous teach-in talks, and direct links to our social media platforms. Also, keep in mind that we'll be selling t-shirts and potentially masks, the pandemic's hottest fashion accessory, in the future. I know I love a cute mask. So there will be a Google form to fill out your information if you're interested in purchasing one of those in the future, as well as joining our email list. Again, thank you very much to all of our lovely panelists. And we hope to see you in 2 weeks for our next segment in our anti-racism teaching series. Thank you very much.
You guys have to allow the panelists to say thank you, and really a huge kudos to you amazing, mostly trainees who have organized this. You are the future. You give me hope. I'm so proud of you, every single one of you, those that I know and don't know. And you really are what is right in the world today. So please give yourselves a huge round of applause.
You guys have been great. Thank you so much.
You really are. I will say, I have been truly impressed with all of your efforts, from organizing all the different marches, everything. I mean, you guys are truly, truly fantastic. And like Dr. Rouce said, you are our future. And I feel like my grandma now. I can almost die happy.
Maybe we can retire sooner than we.
Amen.
The future is very bright.
It is. You guys are truly amazing. And I encourage you to keep it up. And, you know, whenever you need me, I'm here to help. But you guys truly are an awesome group. And I applaud all of your efforts. Truly. You guys are awesome.
We're real blessed to have all of you in our corner. So thank you very much. All right. Thank you all. I hope you have a great night. We'll see you.
Thank you. You too.
Y'all have a good one.
Bye.